Hi.
Hello, I'm here with Richelle Douglas. To get Richelle to introduce herself, we're at RANZCOG 19, the ASM.
Hi, my name's Richelle and I am the Medical Director of SHQ, or Sexual Health Quarters, which is the trading name for the Family Planning Association of Western Australia.
And so, Richelle, you've presented some pretty startling and you warned at the beginning, perhaps triggering research, a study you've done at SHQ today. Could you take us through what you presented?
Sure. So we applied for a grant through the Department of Prime Minister and Cabinet in order to develop and implement a screening tool for intimate partner violence and reproductive coercion in our clinic at SHQ, and also to use that screening tool to determine whether or not there is a statistical link between intimate partner violence, reproductive coercion and unintended pregnancy and adverse sexual health outcomes. So we basically got clinicians as well as consumers, namely women who have been in refuges or social workers working with women in refuges, to feed back to us on exactly how we ask the questions and where we ask the questions. And there was consensus that people actually felt more comfortable writing some answers down on a piece of paper as long as they felt safe and private to do so. And so we essentially developed a 5-question screening tool, and we had input in how we asked the questions. We've now then developed 2 separate waiting areas. So all of our clients come in, they're given their paperwork in a sort of small blue folder. They go into a separate area where then partners and nobody else is allowed into that area, and they fill in all their demographic details but also some answers to a screening tool with the option of discussing this with their clinician. So the clinicians are then trained to look at the screening tool and then do a risk assessment depending on the outcomes of that.
So what's the context of this work? You've presented some of that, why is it important?
So it's really important because intimate partner violence and reproductive coercion affects so many Australians, and it's got a very, very traumatic intersection between reproductive coercion and healthcare. So we know that 2 women a week are murdered by an intimate partner. We know that 1 in 3 women is exposed to physical violence from the age of 15, and 1 in 5 women have experienced sexual violence. We have also seen in Australian data that intimate partner violence and reproductive coercion are a more significant risk factor than anything else for healthcare in women of reproductive age. And so it's a really important area of healthcare that I think as practitioners we don't always want to ask about, because we feel it's like opening a can of worms, and it's really difficult for us to know how to manage it when we do have a disclosure. But what we've found at SHQ is that it's very common. So our initial preliminary data has demonstrated that 1 in 6 people presenting to us identify as having been a victim of intimate partner violence and reproductive coercion in the past, and of them 17% actually wanted to have some same-day counselling to address some of those issues, and 16% said that this was actually happening in a current relationship. So it's a very common issue, and it's also easy to help people to understand the problem that they're facing is not right, and that we can help them to do something about it. So the idea of the project is to empower women who are experiencing domestic violence and intimate partner violence to be able to seek help when and if they want to.
And you found that there was a second, I suppose, arm of the study that sort of looked at a link to outcomes.
Yeah.
So what did you find there?
So primarily we've seen that there's a very strong association between abnormal sexual health outcomes, including sexually transmitted infections and unintended pregnancy. We've seen that women who have been exposed to intimate partner violence or reproductive coercion see to have 2.5 times increased risk of having a current unintended pregnancy. And these data are quite startling because they're only for the first 468 participants. We're hoping to get the data of over 3,000 participants so that we can sort of statistically prove that association.
And where to now with the study and with the findings?
Yeah, so I think the message is really to try to get clinicians to feel more comfortable about asking intimate partner violence and reproductive coercion. As I said in our presentation today, that almost all of our clinicians didn't feel that it was a good idea to ask about these questions. And 3 months after implementing the screening tool in our clinic, 100% of the clinicians felt it had been really important to ask, and that it significantly affected how they managed women and improved the outcomes of the women that they have seen who identified as being victims.
Did you get an idea of why the discomfort with talking about it?
Yeah, so studies have shown that most doctors don't want to ask about it because they feel it's intrusive, that it's sort of opening a can of worms, that they don't know what to do if somebody discloses that they've had a history of intimate partner violence or reproductive coercion. When we did some training, we obviously trained all of our staff in responses to disclosures. And one of the important things is that to recognise that as a clinician, we're not there to solve the problem. We're there to empower a woman to recognise that what's happening to her isn't right, and that she has the power, she's a survivor, she can actually make a difference and improve her own outcome and that of her children as well.
And what is reproductive coercion, just in layperson's terms to understand?
Yeah, so basically it's where one partner controls or manipulates another partner's choices over their fertility. So some people basically stop a woman using contraception if they'd like to use contraception. They ask a woman to have an abortion when they don't want to have an abortion, or conversely, don't allow a woman to seek help for an abortion when they actually want to have an abortion. And manipulation of things like hiding of oral contraceptive pills, they're all examples of different ways that someone can be coerced reproductively. And yeah, it's a very significant issue for women affected by this.
And how much is it on the radar of the college or bodies like this, do you think?
I think it's starting to become more on the radar, but I think that unless we start asking the questions, we aren't going to know the impact of reproductive coercion on women. Studies from Children by Choice in Queensland have shown that women who seek abortions later, so after 20 weeks, are often much more likely to be having been a victim of reproductive coercion, and so have been prevented from getting healthcare when they wanted to at an earlier gestation. So I think I'm hoping that the college can recognise IPV and reproductive coercion as significant risk factors for women's health overall, and in particular antenatally, because when women become pregnant, they're often more vulnerable, and we know that rates of intimate partner violence in pregnancy increase quite dramatically. So it's a really vulnerable time for a woman and her unborn baby.
And where are we at with screening at the moment? Does it happen?
So I know that in Western Australia we have routine antenatal screening for intimate partner violence. The issue is how it's being done. Often people are getting asked these questions in front of their partner, or certainly there isn't a private space for them to be asked these questions, so they're getting asked them in the toilets opportunistically when people actually are quite distracted. So I think that what different care centres need to do is really think about how they're asking the questions, where they're asking the questions, and whether or not the woman feels safe in being able to disclose the answers, because disclosure itself can be an unsafe time for women. It's really important that as medical practitioners we protect women who are also suffering this experience.
So it's about also having a plan for when you ask these questions about what if they disclose and something they say they're afraid and they can't go home, or...
Yeah, definitely. And what we found is that most women, initially at least, just want to feel acknowledged that what they've experienced isn't right. A lot of women do want to get counselling, maybe not today, but in the future. So being able to offer that sort of service. And about 1% of women in our study so far have identified that they want a same-day referral to a refuge, but that number is still quite low in terms of impact on our clinic. Another part of the study that I didn't mention in my talk was that we've actually looked at even our reception staff's view of whether or not screening for intimate partner violence was going to affect patient flow. And prior to the initiation, all of them said yes, it would. And after 3 months, all of them said it hasn't really had a major effect on patient flow at all. So I guess the message for clinicians is that it's easy, that you've got the skills to do it. We're used to asking hard questions, but we need to know what to do with the answers as well. And often it's just empowering women to be able to make their own decisions.
And is this a tool that you receive funding from the federal government to do this study? So is this something that could potentially be rolled out like nationally?
Yeah, I'm hoping that once we have further data and we've got further feedback into the design of our questions and how we've managed it, it is something that we can start training other doctors in. Family Planning WA is in a really quite good position to begin training because we already have a lot of trainees. So we've had quite a few doctors and nurses already coming through the clinic who are using their tool now in their own private practice. So that's really encouraging.
Yeah, that's great. Thank you so much.
Thank you. Sorry, I got a bit nervous there.
No, that's all right. It's always a bit like